So, good morning, everyone. So, our speaker today will be Dimitri Baldwin. And I've known Dimitri for about 8 years, ever since my spine doctor encouraged me to get physical therapy to deal with my kyphosis. He wanted me to improve my strength, stamina, and flexibility. When I told my doctor that I was going to see Dimitri, he said that I had made a good choice and would be in good hands. And he was right. Over the years, I've seen Dimitri for several stretches of time to be sure that I'm doing the best exercises to stabilize and improve my situation. Over this time, I've learned how thoughtful he is about prescribing each exercise to maximize its benefits to me. When I was thinking of speakers for this month, I asked him if he had subjects that he had given talks about, and we decided that arthritis was a topic that many in the old guard would like to know about. Dr. Baldwin graduated with a Doctor of Physical Therapy from Howard University in 2011. Since graduation, he has dedicated himself to becoming well-versed in treating a variety of orthopedic conditions, including postoperative cases, sports-related injuries, and musculoskeletal disorders. Dimitri is also credentialed as a certified orthopedic manual therapist. That's a COMT. This designation of distinction is given to manual and manipulative physical therapists around the world who have completed the postgraduate specialization in the field of musculoskeletal and neuromuscular disorders. He's also received extensive training in treating chronic neck and low back pain using the McKenzie method. This method is designed to help patients achieve self-mastery of managing their own symptoms using exercise in order to help improve their outcomes. Dimitri has worked in a variety of rehab and PT settings, including being the clinical director of the AmeriCare Physical Therapy's Piscataway location. In 2020, he started his own mobile therapy practice called Blueprint Physical Therapy and Wellness. Dimitri recently moved to Montclair with his wife and first daughter. The last month, they welcomed their second daughter into the world. So today, his wife, Sharika, is joining us via Zoom. Today, Dimitri will define exactly what arthritis is, its common symptoms, treatments, and short and long-term management techniques, including the difference between cortisone injections and gel injections. Dimitri, the floor is yours.
Well, thank you so much for inviting me to speak today. That was a very great introduction. Thank you, Jim. I've known Jim for quite some time. I've known his wife as well. Jim is a very stand-up person, and he's always, thank you. He's a very kind-hearted gentleman. So I look forward to doing the presentation today. Today, it's going to be very informative. I will be discussing arthritis in depth. I'll be discussing the common types of arthritis, which includes rheumatoid arthritis as well as osteoarthritis. Now, a little bit about me. I've been practicing for about 11 years, worked in a variety of different settings. I started my journey, actually, interesting enough, when I first graduated school, the first job I had, I worked at a doctor's office. It was a doctor's office, specifically a group of 6 doctors. Each of them had a different specialty. While working there, I had a lot of experience working with patients who had arthritis, specifically patients who suffered from arthritic changes in the spine, hip, knee, shoulder. And while there, we would receive a lot of patients with referrals and given the instructions saying that basically if the patient didn't get better in about 6 weeks, then the patient would have to have surgery. So yeah, can you imagine, this is the first job out of school. And within that time, I had to improve my skills and I had to improve them rather quickly. But what you start to notice after working in an environment like that is certain things. You start to notice the patients that truly need to have surgery, and then there's some other cases where the patient's condition can improve with physical therapy and with other aspects too. So today I'll be discussing in depth some of the more effective treatment programs for treating arthritis. And at the end of it, we'll do a nice Q&A, and we'll discuss if you guys have any questions as well. About 2 years ago, my wife and I, we moved. My wife, Shakira, I think she's tuning in on the Zoom. We moved to Montclair. We welcomed the newborn. I'm still recovering from lack of sleep, but I'll carry on with the lecture. So. Okay, so the common objectives for the lecture today is to discuss the common types of arthritis, as discussed, and short and long-term management techniques. And we'll start with the more common type of arthritis, which is osteoarthritis. Osteoarthritis is the leading cause of disability. This is according to the CDC. In fact, actually $300 billion is spent annually due to medical costs, as well as lost wages due to osteoarthritis. Typically osteoarthritis shows the most changes specifically on an x-ray at about the mid 50s. So 80% start to show some advanced stages of arthritis. Out of that 80%, 60% show symptoms. They exhibit symptoms in terms of the osteoarthritis. So about 240 million individuals suffer from arthritis worldwide. 30 million suffer from in the US. It is also more common in women, and it's more common in women specifically because of hormones which are produced. With women produce a hormone called estrogen. Estrogen has a component in it which helps to reduce inflammation in the joint. Now, as women start to approach menopause, that hormone starts to get produced less. So they're more likely to develop arthritis at an accelerated rate at that point. Also, another fact too is the fact that women also have more lax ligaments, meaning that since their ligaments are more lax, they're more susceptible to suffering injuries, actually. They're more prone to having injuries too. So osteoarthritis is basically described as degenerative joint disease. Degenerative joint disease, because as you look here in the picture, between the two bones, there's cartilage, which works as a buffer, which is designed to absorb the weight and the load of the joint. As we age, that cartilage starts to thin out. It starts to wear and tear over time. And surrounding the joint is synovial fluid. Synovial fluid is a sac which is there to lubricate the cartilage that's between the two joints. So as we age, that synovial fluid also decreases too. And once you start to develop the wear and tear along the contours of the bone, as you see here, they'll start to develop little spurs. And the little spurs are what's producing some of the pain and discomfort, specifically with moving the knee, bending the knee. That's what's causing some of the pain there. Osteoarthritis is also more common. You can pretty much find it in any joint, but it's more common in the spine, hips, shoulders, ankles, wrist. And osteoarthritis also classifies into four main types. So as you look here, there's 4 different stages. On the first picture, you'll see that at that point, there's very minimal change which takes place, only about 10%. As you look into the stage 2, you'll notice that there's the spurs are actually starting to form there. There's a little bit more change to the cartilage, and you'll start to produce a little bit of osteophytes, which is what they call them, bone spurs there. Now, as you start to approach the 3rd stage, that's when you're going to start to notice some more symptoms now. So between the 1st and the 2nd stage, you're not having a lot of symptoms. Primarily the 1st stage, you don't really have too many symptoms. As you get to the 2nd stage, you'll start to notice the early onset symptoms. That's when you start to notice a bit more discomfort. Now, as you approach the third stage, that's when you're going to start to look for other treatment methods to treat what's happening. When you get to this stage, that's when you're going to start to notice pain, discomfort specifically with moving, discomfort with doing daily activities. That could include walking, going up and down stairs, getting up from a chair. Just day-to-day tasks become a little bit harder to do, more painful. At that point, when you go and you see your doctor is going to then say, all right, we'll start you on medications and start to look for other avenues to help alleviate the pain. And as you go to the final stage, that's when about 60% of the cartilage is now diminished now. And that's the severe advanced stage arthritis. That's when you start to notice other changes, such as, besides pain, the pain is now more severe, one. And then secondly, you'll start to notice that when you move the joint, you're starting to hear sounds, starting to produce a sound now. It's starting to produce grinding, clicking. And then at that point, then if you see here with the chart here, that's when the treatment options are a lot more vast, because at this point you needed a lot more. So for instance, I'll discuss it in a couple of the other slides too. But for instance, when you compare stage 1 to stage 4, stage 1, you're not doing anything. You can just stretch. That's if you're an active person, you'll just stretch. That should alleviate it to some extent. So by the time you hit stage 4, then that's when you're looking to implement medications, possibly surgery, depending on the situation. Okay, signs and symptoms of arthritis. The first one is pain. Pain is a cardinal sign. That's one of the more common complaints we typically hear from patients, and that's pain specifically with movement. Also pain when you're getting out of bed first thing in the morning, pain if you're sitting for a long time and then you start to transition up, you start to notice some discomfort in the joints. Loss, another sign too is loss of mobility. So you're starting to notice a gradual change in how effective and how freely you can move your joints. That occurs over time. Also sounds, as discussed before, it starts to produce cracking, scraping sounds specifically with movement. Now, with this slide here, if someone's experiencing this sign, specifically like blocking in a sense where I'm trying to bend my knee and it kind of seizes in place and it's locked and you can't move it, that may mean something else besides the arthritis. So remember, as it goes back to the previous slide with the cartilage is thinning out, right? So once it thins out, sometimes it can actually, you can start to develop loose bodies where it can actually break free. So if you can imagine, if I have a door and I open the door and something gets lodged between that, the edge of the door, the jamb of the door, I can't close it. It's kind of like similar to your joint. So if I have my two joints, this is for just to kind of demonstrate. If I have my two joints and something is lodged in between, I can't fully bend it. Now, if someone's experiencing symptoms like that, then that's when they would have to see a doctor. The doctor would then send them out for further diagnostic testing and MRI, etc. And that's when it could possibly mean torn meniscus or some other form of loose body in there. Another sign too is swelling. Swelling is a very common sign also too. Now, with arthritis, osteoarthritis, there's two classifications. The first one is a primary arthritis and the second one is a secondary arthritis. Now, the difference between the two is primary arthritis. When I say risk factors, I mean what's driving it, what's causing the arthritis. Primary just means that that's for the group of people that primarily have it just due to genetics. It runs in their family, they've just developed it. That's their main reason why they've developed it. Secondary arthritis, however, is the arthritis developed from some other sources. For instance, injury. If you injure your bone, you suffer a fracture, it leads to it sort of exacerbates or expedites the arthritis to come about a lot sooner. Another common factor too is abnormal stress on the joint. Now, when I say that, I mean it depends on your occupation. If you're someone who's on your feet all day, it's a very laborious kind of job. You're squatting, you're bending, you're putting a lot of load on the knee. You're causing a gradual wear and tear on that joint. And if you're doing that and you're doing that for 8 hours a day for years on end, then that arthritis is going to get expedited a lot faster too. Another common factor too is obesity. Obesity, if you're thinking about it, it puts a lot of weight and load on the joints. Now, this is interesting because they say that, this is according to research, they say that with each pound that's lost, it takes about 4 pounds of load off of that joint. So that's why oftentimes you may have your doctor stress, to lose weight, because that's taking a lot of pressure off of the joint. Another factor too is inflammatory conditions such as gout, RA, Lyme disease. Muscle weakness is important. Muscle weakness primarily important because it's overlooked. Now, it's overlooked because you may just kind of develop the arthritis over the course of time, but still not exercise. And the thing is that if you think about it like this, if you compare the state of your body now to where you were maybe about 10, 15 years ago, right? The arthritis at that point probably had more cushion to work with, which means that you weren't feeling as much symptoms, and secondly, you didn't have to do as much to protect your knee, to reduce the load there, because you had more cushion to work with. Now, as we age, it gets thinner and thinner. Now, once that happens, if you have muscle weakness, the muscles are designed technically also to help support the joint. Now, if you have your knee and my muscles surrounding my knee are weak, I'm putting more load onto my joint. So before, you may have gotten away with not having to do as much, but now as it starts to wear down, it's important now to start to exercise to help protect that knee and preserve the knee as much as you can at this point. And muscle weakness is another factor too. Age is another factor because you'll start to see a lot of the changes, as mentioned before, in the mid-50s with in terms of the advanced stage. Now, pharmacology. So acetaminophen and oral NSAIDs are given. So these are technically like the first line of defense. You go to see your doctor, you tell your doctor, hey, I have discomfort. You'll just be given medication. That's one of the first forms of treatment now. So there's two main types. So now you have your topical medication, and the topical, you go and you put an ointment there, and then you have oral medication you can take too. Now, the topical is not as effective as the oral, but it has less side effects gastric wise, right? So they both have like their pros and cons too. So that's one form there. And joint injections. Now, so there's two main types. You have cortisone injections and you have hyaluronic injections. And the cortisone injections are basically to help reduce pain and inflammation. Now typically this is given when someone has a considerable amount of pain, and it's designed to help alleviate the symptoms now. So ideally when they're given spaced out throughout the year, ideally about 3 to 4 you can get throughout the year. And the reason being is that if you have it consistently for a long period of time, it actually leads to more wear and tear on that joint, more wear and tear on the cartilage. So that's why it's designed to be spaced out as it is. As far as gel injections are designed to create a form of lubricant in the knee. So with the synovial fluid that's in the knee, it decreases over time. So now when you get the gel injection is designed to give that sort of buffer there. Now, the key thing is this. It truly does also, a big factor too, truly does depend on the stage of arthritis you're in at that point. Now, you're going to find that if I get a gel injection, it's more effective in the middle to earlier parts of the stages of arthritis. Towards the end, it may be less effective. And that's because you have less cartilage to work with at that point. So the gel injections, they're designed ideally to last for a couple of months on out. Now, there's two main types. Orthovisc is a big one. Uflex is another one too. But if you're receiving gel injections and you're not responding well to it, then that usually means that at that point, the arthritis is pretty advanced. It's pretty far along there. And the gel injections are also given out in series. You'll have to go back every week for a course of about 3 or so. And physical therapy, I'm a little biased towards physical therapy, but physical therapy helps with improving the overall mobility in the joint. So with the arthritis, you develop more stiffness in the joints, lack of mobility. Physical therapy helps with improving that. Also helps with improving the strength. Now you need the strength because the strength is going to help to take pressure off of the joints, and it's going to take some load off of the joints too. So you need a combination of strength, mobility, and if you're suffering from any other ailments such as balance, then everything gets incorporated into that too. Now, I have 2 pictures. Now, with physical therapy, ideally, the overall goal would be to improve optimal posture, 1, and then also to improve taking the max amount of load off of the joints. Now, the first image, if you focus on the first image with the gentleman with the blue shirt, he has 3 different images, right? Ideally, the goal would be to get him to the last image where he's standing upright. And in that position, that takes the most amount of load off of his knees, off of his hips, off of his back. And the reason being is this: when one joint is affected, it affects other joints. So you may have one knee issue to begin with, but then if you notice over time, you may start to develop issues with your ankle, your hip, your back. That affects the way you're walking. Now, at that point, even if you do have a knee issue, you can't necessarily just treat the knee issue by itself. So even if you're getting shots, it's not going to be as effective if you're just treating that one specific thing. You have to treat the whole body, because at that point you want to take as much pressure off of the load, and then you want to improve one's ability to walk without increasing the amount of stress on the joints. Another common thing that I noticed too is if you don't have the appropriate assistive device, meaning that if you're not using a walker to the optimal size, or if your cane is too small or too low, that can also create more load on your joints. Because if it's not at the appropriate height, it's kind of counterproductive no matter what you're doing, because now at that point you're just increasing the stress on your joints too. Now, surgery. So with surgery, there's typical characteristics that you'll know when someone's ready for surgery. So, as a physical therapist, we'll see this a lot. And with surgery, it depends, because typically the person has hit that advanced stage of arthritis. At that point, the pain is a lot more debilitating. The pain is the person can't do basic day-to-day tasks. With everything that they're doing, they're experiencing severe pain. They can't stand for too long, walk for too long, use the stairs for too long. They feel like they need to rest a lot. The pain is, you can't really manage it much with medication. They've tried other options. They've tried steroid injections. They've tried gel injections. They'll typically may mention, hey, look, I've tried taking this injection. It feels like it only lasted a couple of days, or then those are some of the signs at that point. That's one sign as it relates to physical therapy. There's other aspects of it too. As mentioned before, severe pain. Another thing, you can't really control the amount of swelling in the joint too. Another factor too is the age. With the age, typically the best kind of candidates are over the age of 60. And that's because with the replacements, they're designed to last for a period of time. So you don't want to implement them too early on. For instance, like someone's in their mid 40s, especially when they're designed to last ideally 15 to 20 years now. So that's why it's meant to delay it as much as you can to where it's about the mid 60s or so. Another big factor too are contraindications. That just basically means that there's not a lot of health complications that are involved. Another factor too is non-smoking. Smoking affects your immune system. So if someone's an avid smoker, then that affects your body's ability to heal. Now, if you're having surgery, that can impact that immensely. So that's why that's a main criteria too. So another main common form of arthritis is rheumatoid arthritis. Now, I would say the biggest difference between the two is that rheumatoid arthritis is the more debilitating of the two. It's a lot less common. It's common in about 1%. Once again, it's more common in women. Peak years are between 40s and 50s, and there's no cure. So there's no cure with osteoarthritis either. But the overall premise that I want everyone to know is that even though there's no cure, it could be managed, and it could be managed to some extent. It's about just doing things to help with it. With RA, about 50% of people start to develop some form of disability within 10 years. Rheumatoid arthritis is an autoimmune disorder. So it means that the body's attacking itself. It's attacking the healthy tissue in the joints. It's attacking the lining of the joints. So another fact too is that since it's an autoimmune disorder, it not only impacts the joints, it's impacting other organs in the body as well too. So if you look here, between the first image is a normal joint, and you can see the little gray area where the cartilage is. Now you compare that to osteoarthritis, and you can see that wear and tear has already taken place. Now, as you compare it to the final image, you can kind of see where it's completely swollen, specifically around the joint. And that's because the lining of the joint has now been affected. Now, when that happens over a period of time, it can cause bone erosion at that point. And because it's attacking the joint, it's a severe level of pain that somebody's experiencing. With RA, people tend to have flare-ups, which last, it could range from weeks, months, and they have remission periods too. With RA, some of the signs and symptoms include swollen joints, warm joints, tender, stiffness, of course, fever, fatigue. It normally impacts the smaller joints first, which means it impacts the joints in the fingers, feet. Eventually, it'll start to affect the other joints. It affects the ankles, knees, shoulders, hips, and usually it's both sides. Big difference too with osteo. It can happen mostly on one side. Someone may have just issue with just one joint. With RA, it's both. It can also have secondary effects too. So individuals with RA are also more prone to osteoporosis. And that's simply due to some of the effects from the RA, as well as some of the medications. Now, because of that, the bones are more susceptible to fractures. It also causes rheumatoid nodules, which are just firm points where you'll find on the elbows. Dry eyes, that means diminished moisture in the eyes, more prone to infections too. Carpal tunnel specifically because in the wrist, your nerves travel underneath there. So if there's inflammation there, it can also cause compression of the nerves in there. Heart issues mainly because it affects the lining around the heart. Lung disease, it causes scarring in the lungs, which can produce shortness of breath. Lymphoma, which is a form of cancer. The signs and symptoms, they come and go in terms of some of the flare-ups that someone experiences. Eventually, it can also cause deformity in the joints too. Some individuals may just start to develop abnormalities in the joints. Risk factors. Common risk factors include family history, which is interesting enough. There's no specific cause. There's nothing you can pinpoint and say, hey, like this is what causes the RA. What they have found is that there's a linkage. There's some small linkage, meaning that if someone's genetically has that component of RA, then when they come in contact with another factor, environmental factor, that increases the likelihood of the RA. So meaning if I have a genetic component and the other factor is obesity or smoking, that can increase the likelihood of developing the RA. That's from what they found with the research. Age is a factor. Smoking, of course, more common in women. The common forms of treatment include physical therapy to help improve function one's ability to move. Occupational therapy to help improves one's ability to use to perform day-to-day tasks such as getting dressed, putting on clothes. You may lose some ability to write in some cases too because of the joints. Medications is a big factor. Anti-rheumatic drugs. And now, other recommendations I found online to include, I've gotten this specifically from the Arthritis Foundation. This is a great resource also to in case anyone wants to read up on it. But they have their recommendations in terms of foods which can also have components in them that can also reduce and control the inflammation. So according to them, they mention fruits and veggies. So eating fruits and veggies, two servings at least per meal. And some of the more common types that they recommend are blueberries, blackberries, cherries, strawberries, spinach, kale, broccoli. Fish, certain types of fish that are high in omega-3s. Recommend about 3 to 4 ounces. This includes salmon, tuna, anchovies. That's one. It also mentions eating nuts, about a handful of nuts, specifically walnuts, pine nuts, pistachios, almonds. It also mentions beans, eating about 1 cup of beans twice a week. Pinto beans, black beans, red kidney beans, garbanzo beans. Olive oil was another thing that they mentioned, about 2 to 3 tablespoons of olive oil. Specifically, they recommended using ones that are produced in dark bottles because it helps preserve the freshness there. Onions helps control bad cholesterol, also helps with the inflammation. Fiber, specifically carrots, peppers, helps with reducing inflammation. Another big thing too is processed foods, specifically cookies, chips. They can actually increase the inflammation. So that's a big thing. So instead of eating that, it recommends eating fruits and veggies instead. Also to avoid canned foods, whether it's canned soups, instead to seek other alternatives such as frozen vegetables. Frozen or fresh vegetables too. So to recap, what I covered, some of the more common ways of treating osteoarthritis as well as the rheumatoid arthritis, as well as the main difference between the two of them. So is there any questions?
I'd be curious to your reaction to what appears to be a contradiction of terms.
Yes.
Early in the talk, you talk about reducing stress and load.
Yes.
Doesn't physical therapy create stress and load?
No, not at all. With physical therapy, the goal would be to strengthen the muscles, and there's ways that you can strengthen it without creating load on the joint. For instance, since the knee has to absorb a lot of weight, you would start someone with doing exercises on a table to help strengthen the muscles surrounding there. Also, too, there's other muscle groups that are involved with holding the weight of the body, assuming the weight and load of the body. So there's ways you can do it without creating stress and load on the joints. And the only way to really trigger it would be someone would have to be doing some form of strenuous exercise, meaning like they're bending, squatting, doing things of that sort would definitely trigger it. But an exercise program consisting mostly of stretching, some strengthening, some mobility exercises, some take-home exercises to do that focuses on other body parts too. Because once one joint is affected, meaning that if someone has a problematic knee and the knee is it's out of sorts in the way, that means it's not moving correctly. So the focus should be on trying to improve the way that the knee moves, one, and then to strengthen the muscles around it at that point so that it can move more efficiently when it's standing. And then to address all the other lingering things too, because once that knee develops, there's other secondary things that take place. Your hip, your ankle, your back, you correct that. And then it should make it a bit easier for that person to function at that point. No problem.
Okay, Dimitri, thanks for a great informative
presentation. My question is, like an arthritic, say knee or any kind of joint, would the application of heat be of any benefit?
It's a short-term effect. Yeah, definitely. But everything is short-term. You know, it's yeah.
Okay, thank you very much, Dimitri. Very interesting. I've developed osteoarthritis in one knee, and I've been doing PT for a year, and it's feels good, feels I'm strengthening, but the inflammation hasn't gone away. So I'm frustrated. You know, I want this to be under control. I'm skeptical about the gels and the other stuff. Maybe I shouldn't be, but maybe you've run into other patients with this story. What do you suggest?
It depends. Is it more concern about the inflammation, or is it just the overall discomfort in the knee that you
What I
wanna
really
address?
I feel more, it's a little painful, but I can live with the pain. But I
understand.
sometimes walking downstairs, I feel like my leg may give out on me,
I
and that's
see.
scary.
I see. Now with the exercise program, has it evolved over time? Has it changed, or you're doing pretty
Yeah,
much?
and I'm just doing it once a week. Maybe I'm not doing it often enough. I just do it
Wow.
once a week.
Yeah, that's a big factor too. Typically with the exercises, ideally to do them daily. You can also start to think about wearing some sort of support tool around the knee, like some sort of brace there that
Mhm.
can help strengthening exercises daily though. That should start to help with the buckling, I would say primarily. With the inflammation, it's a little complicated because there's maybe more involved with that. With the food recommendations, I'd say you can also discuss with your doctor because that may help too. Outside of that,
No, that's good. That's
Yeah,
good.
yeah,
That's good advice. Thank you.
yeah, it's gonna work out, Bill.
It's Adrian Hartman. I think it might be my turn. So at a pause here, I'll ask, would any food supplements such as omega-3 oils help with the lubrication of the joints? And if so, what dosage would you recommend or pill size?
So as it relates to meds, I can't specifically make any recommendations. As a physical therapist, it's outside of my scope. I would say with those, I would ask your doctor, specifically with making the recommendations for the type of foods. Yeah, it's outside of my scope in terms of advising you on that.
Okay, thank you.
I'm his wife and I have a question too. I'm
Hi.
falling apart slowly. I've had my right knee replaced and I'm trying to avoid having my left knee replaced. I've also had both hips replaced. So as
Wow.
I say, I'm falling apart. But what I find is if I go for a walk, I'm as likely to have my supposedly fixed knee bother me a little, hurt a little. It doesn't really hurt, it doesn't pain, but it feels funny. And I don't know that it's, speaking from physical therapy, is there something, since the knee has been replaced, supposedly it's in great shape now, what is likely to be going on? And is there something with physical therapy that might reduce that discomfort?
Yes. So with the other knee, what happens most times is that since one was replaced, the other one may be running a lot of the load too. So it may be taking on some more weight. Because even as you were rehabbing and recovering from the injury, from the surgery, the other leg had to support the body a lot more. So you may be experiencing some of the residual effects of that. I would say that left knee needs to be rehabbed too, because now you need to work on making that leg as stable as possible. That's primarily a factor too. I also want to mention too, sometimes it's not as straightforward as the joint. It could be the hip that could be giving you some issues too. There's muscles in the hip that are responsible for improving the way that you walk, improving your mechanics. Another factor too, the ankle. If the ankle's not moving right, if it's not moving optimally, it creates other issues elsewhere too. That then can affect the way you're walking too. So everything is kind of, it trickles. And especially since you had 2 hip replacements too. Now, it depends on the kind of rehab you've had. Now, sometimes people may develop a little bit of the waddling gait where the muscles are weak, so it kind of rotates almost. So that could be an element too. So I would say first thing, seek therapy specifically for the left side. Also to stress to them that you want to work on the hips, the knees, all of pretty much the body there, so that you can improve your ability to walk. Because you're really, ideally, you want to prevent having another procedure on the other side. So I would say rehab those 2, because sometimes it's the other factors that are implementing everything else too.
Thank you.
Yes.
Thank you for your very thorough and comprehensive presentation. My
Thank you.
question relates to glucosamine, chondroitin, sulfate, and over-the-counter treatment. What is your experience?
You know what's interesting? I read an article. It said that there's not a lot of research with how effective those are. So with that specifically, there's not a lot of evidence with how effective it is with reducing the symptoms.
Okay, thank you. Really enjoyed your presentation. Sorry, I didn't catch the very beginning of it. I had a hip replacement last May. And so what you were saying about the wrong size cane and the walker, all very familiar. I wish I had heard it a year and a half ago. But anyway, since I had my hip replacement, everything's fine. I play tennis now and, things going well. But what you said about the rheumatoid arthritis scared me. So my question is, can you get both the regular arthritis and the rheumatoid arthritis? And if you do have rheumatoid arthritis, are the fruits and blueberries and vitamin D to reduce it or to prevent it?
So the osteo can happen either way, because that's just wear and tear on the joint. The rheumatoid, however, is a little different just because it's systemic. It's an autoimmune disorder. So osteo, you can definitely have it with that too, because let's say, for instance, you're someone who's really active and who uses their arms a lot too. Because that happens over time, you'll start to develop wear and tear on those joints anyway. So there's that element that may happen either way, even with the osteoarthritis. Now with the rheumatoid, it's more so the other factors like the genetic component as well as the other factors that may trigger it. So from what I've read, it's those risk factors that are really defining whether someone gets it. It's the underlying other elements too. It's the age, it's the smoking, obesity, it's environmental factors. It's those factors that specifically contribute on top of the genetic component that can trigger the RA to happen.
Thank you. Well, what I'm sorry. With the diet of blueberries and cherries and vitamin D, bring it back down or prevent it, or
you know what? Those were recommendations to help reduce inflammation.
reduce inflammation. Okay.
The thing is, it's like I understand what you mean. Those are recommendations. They're not like preventative recommendations. Those are recommendations like to control. For instance,
Coping,
for instance, all of the fruit groups they mentioned have properties in them that help to control inflammation. Like it'll specifically to work with a specific protein that helps to control the inflammation. So they're not really designed to use as preventative methods. They're just to control the inflammation that's happening.
Thank you.
Hi, thank you
Thank
for
you.
this presentation. I have a question. I don't quite understand what you mean by muscle strengthening. The reason is men in this group, I think, we have a low dose of hormones, and those hormones are essential for muscle growing. So basically, we in this room, we cannot grow muscles. So what do you mean about muscle strengthening? What happened at the physiological, the pathologic aspect of the what happened in the muscle when you say that?
So what I mean is that there's many elements to it. So what's happening physiologically too with the joint is that because of the spurs that have developed and because of the diminished cartilage, it doesn't move as well. There's less fluid in there too. So with treating it, you want to, one, help it move better. So when that joint is moving a lot better, the muscles can then work optimally. So for instance, so if someone has pain, and that's one, and if the muscles and the joint is not moving correctly, the length of the muscles cannot contract effectively. So that's one element too. So now, if I now help to improve the mobility of that joint, that muscle can then work more optimally to contract and move. So to further clarify too, if I have my knee has a contracture to it, right? I have a quad tendon that attaches from here and links onto here. So with just basic physics, if my knee is flexed like this, my muscles cannot contract effectively because of the deformity that's happening in the knee. So because of that, I would have to help reduce that deformity so that way when that muscle has to fire and contract, it can work effectively to contract that muscle. So even though there's age-related changes that take place, the muscles would have to be in a more optimal position to work effectively to help to stabilize the knee. So there's many different elements. There's not only strengthening, because it depends on the type of strengthening you're doing. And then on top of that, you have to implement other things too. You have to improve the way that the joint moves so that the way that the muscle can contract effectively. Another example I can give you too, if I have a contracture here and I have, so let's say my arm was in a sling. My arm is now in this position like this. It can't move, it's stuck like this. If I try to, let's say, contract my tricep, just like this, right? My tricep, it can fire, right? But it's just not gonna move. And it's not gonna move because the joint is restricted here, and I have another muscle that's binded up and not allowing it to move. Now, if I then work on loosening up this joint, and now if I try to fire that muscle now has the capacity, it has more of a laxity there to help move it better. So with the arthritis, the goal is not only to mobilize and stretch the joint, but now once the joint moves a bit freer, the muscles can then work a bit more effectively. Even in spite of age-related changes, it can then work still a bit more effectively because now I've allowed that motion to take place. And now at that point, that muscle can then fire more efficiently. Yeah, does it make sense? Yeah, not quite. It's not necessarily the same, because what I'm saying is that I'm describing the treatment process and what we're doing. So you can stretch a muscle, but it's gonna recoil back either way because the joint impacts how efficiently that muscle can move, right? So you have to mobilize the joint. One, you have to stretch it, but then at that point, you have to then try to activate that muscle to then work too. So everything ties in some ways too. I understand what you mean with the stretching. I see. But the thing is, by mobilizing it, you're still stretching, yes. But then at that point, you have to do specific exercises. It could be eccentric exercises. It could be concentric exercises. Try to stimulate that muscle to work at that point. So that after that, then that's when you'll have more. It creates more of an efficient ability for that joint to move, one, and it creates more efficiency for that person to walk and move and to move really. Does that make sense? All right. All right. That was a good question. That was a good question. I like that.
Thank you, Dr. Baldwin. You certainly picked the right audience to speak with today.
I know.
If I'm not mistaken, I heard you say that in the case of osteoarthritis, that acetaminophen would be the preferred drug, whereas with rheumatoid, thank you for helping me capture that. With rheumatoid arthritis, it sounded like NSAIDs would be the more appropriate drug. Is that because of the inflammatory nature of the rheumatoid arthritis?
Yeah. Rheumatoid, it's because of the nature of the condition, the drugs would have to be a bit more potent. So with that, they're given harder, in that case, harder drugs, and they're giving anti-rheumatic drugs too, because of the nature of that specific condition. The osteo, those drugs and acetaminophen, they're given specifically just to manage it just for a bit. But definitely because of the potency of the RA, the drugs are a lot different. Yeah.
Yes. Dr. Baldwin, thank you so much for a very informative talk. I have a question about origins, causes of osteoarthritis. And because in my case, I had a double hip replacement, and it was quite some time ago. And I remember going to the classes that they ran for people, sort of my cohort of people who were having that operation in the same time frame. And I looked around the room and I saw that I was by far the youngest person in the room. And so I guess I had early onset osteoarthritis. Now, naturally, I asked the doctors, what causes this? I mean, why am I getting this, at a much younger age, if this is really something that normally I would get later? And of course, they would not even offer a theory. None of them, basically the answer is, well, they don't know what causes it and they weren't going to speculate. But I have a theory, and maybe I read this somewhere. When I was young, I used to run a lot of marathons. And so that was a lot of hours of pounding the pavement, and literally the pavement, because, I run for hours on roads. And, so that causes a lot of pounding of those joints. And, over time, maybe micro tears or something like that, which didn't show up at the time as a problem, but might have led eventually to arthritis. What do you think?
So yeah, definitely. That's actually one of the risk factors too. So one of them I mentioned, it's the kind of work you do and how active you are. That plays a big, huge part, specifically because the more loading and pounding you're doing on that joint, it can exacerbate that arthritis there. The numbers in terms of the age groups, when someone typically notices, it's more of in most cases, but it's not a general thing. But the biggest thing I would say I notice even from treating patients too, is that it's the same equivalent. Like if you're a football player and you're constantly loading that joint, you're exercising, you're doing squats, you're pounding the pavement, that person is going to develop arthritis a lot quicker than someone else who doesn't do that. So the activity level plays a big part too.
Thank you.
Yes. You will probably recognize hydrochlorothiazide, irbesartan, cephalosporin as old, tried and true drugs for, I think, blood pressure, cholesterol, etc. They also have a side effect of crippling joint pain. Are they recognized as maybe a trigger or a crippling condition that leads to arthritis? How do drug side effects figure into joint pain and arthritis?
With the drug interactions, I'm not sure. I'm not sure really, because based off of the research I did do, most of it was the factors that I mentioned. Not a lot of it was mentioned in terms of the drugs, but what I will do, I will look into that actually with the drug interactions. Yeah, but I would say, throughout the research I did, most of them highlighted specifically other main factors which contribute to it, primarily with the osteo. But as far as that, I'll have to look into it and get back to you on that. Yeah.
Well, unfortunately, I've had a bad experience with these 3 drugs, and I don't take them, and I don't have joint pain.
Okay, thanks for muting me. It was very informative talk. Do you do any treatment for like nerve pains in the feet?
From the nerve pain. Nerve pain could be caused from a couple of things. It could be diabetic. It could be caused from a pinch nerve coming from somewhere else. Not so much related to anything else. Yeah. Nerve pain, not so much. No.
Like, so you don't do any of that type of treatment, like say to increase the blood circulation in the feet. You don't do any treatment like that.
I'm sorry. Can you repeat?
You don't do any treatment to treat the pain in the feet, like increase circulation of the blood in the feet. You don't do that, do you?
Oh, physical therapy.
Yeah.
Oh, yes. If it's circulatory, then it could be a couple of things now. So now, if it's something that's producing symptoms in the feet to that extent, it could be coming from a circulation issue. It could be a nerve issue. It depends on the kind of pain you're having. Now, if you're having pins and needles, that's one thing. That's more nerve. That's something that could be treated. If it's circulatory, then you're having like symptoms where it depends on the positioning of your foot. It depends on how active you are. It depends on if you're walking and you're experiencing like little prickly pins and needles sensation on the base of your foot. That's a bit different. Or sometimes too, you would have to get that ruled out primarily from a vascular doctor if it is vascular related. If it's nerve related, it's a bit different now. Nerve doesn't specifically isolate to the foot. It's more, it could be, if it's specifically a nerve, it tends to run along the tract. It tends to run along the side of the leg, a specific pattern, the back of the leg. It's not based specifically on the bottom to that extent. So if it is blood related, then you would have to see a vascular specialist about that. Because with the therapy, the most you can do is do some sort of exercise, aerobic exercise. But if something's occluding the flow of blood, then it's not going to be effective, really. Yeah, if something's blocking that, then that could be affected too. Or sometimes too, it could just be as simple as being a calcium issue, potassium issue that's causing cramping. But you would have to get those things ruled out first from the doctor. And remember, too, if it's vascular, if you think about what's happening to you, the more you exercise, the more blood flow that needs to go to that specific area. If something's blocking the flow of that, then there's not much you can really do physical therapy wise. That needs to be addressed in another way. Only if it's more nerve, something's compressing the nerve, it's blocked somewhere along the pathway, then that's a bit different. And remember, the nerve, it follows a pathway. It's like a circuit system in a house. If I close this side, it affects one side. If it's not necessarily isolated to just the bottom of the foot. It'll just run along the pattern, along the side, along the back of the calf. It runs along a specific path. So yeah, I would consult with the doctor first if it is vascular.
And it was operated on and was completely cured. It's still since then, but I didn't take any pills. I decided to do it another way. I always liked water, and I was a swimmer, and I started exercising in the water every single day for 40 years. And it really kept it in totally dormant.
Yeah.
And I have to say that it came back now. It came back now, and when I went to a what do you call the doctors who do the
Rheumatologist.
yeah.
Yeah.
Give me kind of a break, not permanent, you take on and off, and I drive, and it makes you more aware of things.
Yeah.
That same with your leg, and it also keeps some pressure on it, which helps a lot.
Yeah.
Another thing I wanted to mention, when we all talk about inflammation, we talk, what about this turmeric thing? It's a kind of root which helps against inflammation, and it's big in the news, and I started taking it. Shall I continue?
Yeah, the turmeric. Yeah, I understand. I can't really, I can't really prescribe or recommend that. That's purely just because it's outside of my scope of practice. Yeah, that specifically would have to ask your doctor. Yeah, turmeric. Yeah, definitely turmeric. Yeah, definitely.
And then it will subside, and then we never overdo it either. Nothing is not good, but too much is not good either. That's how it's about.
No problem.
Down to my level here. Dimitri, so that was a great talk. You certainly stimulated our audience online and here to ask lots of questions. Thank you so much. So we have a couple ways of thanking you. One is through a certificate, which that's here, and we need to tell you about the orchid that's on the certificate. The Summit Old Guard was founded in 1930, and at that point, Summit was the orchid distribution capital of the world, and so that's why the Summit Old Guard chose the orchid as something they wanted to display on their. So we have that for you, and we also have the Old Guard salute.
Once again, I want to thank you guys for inviting me. It's been a pleasure. Feel free to reach out to me. I'll stay back. You can chat a bit more afterwards. Thank you.